These are in listen-only mode.
Hello and welcome. I am Catherine Poole, President and Founder of the Melanoma International Foundation. And tonight we have the pleasure of bringing Professor of Neurosurgery and Director of the Gamma Knife Services at Yale, Veronica Chiang. Veronica will present an informative slideshow and discussion on radiation and the treatment of melanoma brain metastases. I do want to apologize to all of you who may not have gotten the time change, but we're getting going here anyway. We're about 15 minutes late. So I want you to be sure and stay tuned, though. At the end of the program, we will be answering all of your questions that you sent to us. And again, thank you for coming tonight, and welcome, Veronica.
Thank you, Catherine. Thanks for your invitation, and thank you for the opportunity to give this webinar. As you said, I'm going to be talking tonight about radiation treatment of melanoma brain metastases. And so I just wanted to start by talking a little bit about melanoma brain metastases. I'm pretty sure that many of our audience probably know a lot of this already, but melanoma really has a predilection for oh, I'm sorry, next slide. I'll get there. A predilection for central nervous system spread. So melanoma likes the brain. And over the course of patients' remaining lifetime, somewhere between 30 and 70% of patients with stage 4 melanoma will develop brain metastases, and that rate is even higher at time of autopsy. In fact, the rate of melanoma metastases is so high that it's now the third most common cause of CNS metastases following lung and breast. And in patients who have good control of disease outside the brain, unfortunately, up to a quarter of patients will actually have their first site of relapse in the central nervous system. If the brain metastases are not treated, it can actually contribute up to half of melanoma deaths. So historically, melanoma brain metastases has not been a good discovery for patients. The brain metastases from melanoma can actually grow relatively quickly, and so the risks associated with having a metastasis is that if it grows to a size that's big enough, it can cause neurological symptoms from just having the lump there in your brain in an area that's functionally important. As with all other brain tumors, having a spot of cancer in your head can cause seizures. But specific to melanoma is the risk of bleeding. And so melanoma cells in the brain can cause spontaneous bleeding in an unpredictable fashion. And as we go back and look at imaging studies of people with brain metastases, you can actually see bleeding in the melanoma tumors themselves in up to about 30% of cases. And so because of the risks associated with having melanoma metastases in the brain, the melanoma group here at Yale has actually moved towards a very aggressive screening approach to finding these lesions when they're small, before they bleed, before they grow and cause mass effect. And the idea is that the smaller and the earlier you find these lesions, the less risk there is from the lesion growing or from treatment, in fact, of these lesions. Next slide, please. And so what are the treatment options for melanoma brain metastases? Well, as with metastases from in any other location, there's systemic therapy. The CNS has been thought to be a place that systemic therapy typically doesn't go because of something known as the blood-brain barrier. The blood-brain barrier is a physical barrier that does not allow foreign agents into the brain. And what we've learned also over the years is that in addition to that, not only is it a physical barrier, but there are actually portions of the blood-brain barrier that actively spit out things that are foreign to the brain back into the bloodstream. And so at this point in time, while we think that there's probably some penetration of systemic agents into the central nervous system, they certainly cannot be relied upon to take care of all of the central nervous system disease. Surgery obviously is an option. If you've got a single lesion that's on the surface of the brain, sometimes these can be removed. Or if you've got a large lesion or a lesion that is bled, then those can be treated by surgery. But typically, in stage 4 cancer patients, surgery is not considered a good option, and obviously if you've got more than one lesion, then this is not a good option either. And so the last option for treatment is that of radiation. And over the last 50 to 60 years, the only option that has been available for radiation treatment has been whole brain radiation therapy. Interestingly enough, despite the fact that it's been used for many decades now, there's not a huge amount of reporting specifically about the impact of whole brain radiation therapy on melanoma brain metastases. But what people have reported is an overall median survival of only about 2 to 4 months, even following whole brain radiation therapy for melanoma brain metastases. And there's a fair amount of anecdotal experience out there talking about melanoma metastases regrowing in the brain after whole brain radiation therapy. Next slide, please. And so what I wanted to talk about today is the newer option of something called radiosurgery, or gamma knife in our facility. And so what I wanted to do was to compare a little bit the two options. So if you look at the left side of the screen, whole brain radiation therapy is the delivery of a small amount of radiation to the whole brain over a 2 or 3 week period. So you come in every day for a little bit of radiation, and it treats the whole brain. Whole brain radiation therapy is still considered standard of care across the country. And the reason for this is because if 1 or 2 melanoma cells were smart enough to get up into the head, that you may have, or the patient may have, more than just those 2 spots. And because our current imaging capability does not allow us to see down to the cell level, so whole brain radiation therapy allows the treatment of the spots that we can see, as well as any other cells that we can't see yet. The disadvantages of whole brain radiation therapy, however, are, as we talked about, that many of the lesions do tend to regrow after a period of 1 to 4 months. It can only be used one time because the whole brain radiation therapy is dosed to the maximum dose that's tolerable by the normal brain cells. And as most of you know, during the delivery of whole brain radiation therapy, there can be nausea, appetite loss, hair loss, vomiting. And then in the long term, things like, people don't see so good, hear so good, they get tired. And the most important, or the most concerning long-term side effect is that of neurocognitive dysfunction. And that comes really from radiating a whole bunch of kind of normal brain. And so things like attention and memory and multitasking and things like that can be affected. What we know is that the longer that the patient lives after whole brain radiation therapy, the more likely that that risk occurs. But what's difficult to know is how much impact that will have on people in the long term. So we've certainly seen patients who have done very well and have not really had a significant functional impact from whole brain radiation therapy, and then we've certainly also seen the other end of the spectrum, where there are people who are functionally devastated from whole brain radiation therapy, and our inability to predict who will have what degree of neurocognitive impairment is the difficulty with whole brain radiation therapy. So moving on to radiosurgery. Radiosurgery is very different. It's a one-day outpatient procedure. All of your radiation is delivered on the one day at one time, so it's what we call single fraction. But it only radiates the tumors that we can see. The advantages are that there are very few side effects up front from the radiosurgery, and that even after use of radiosurgery, you can, if new spots pop up, then you can either get treated with radiosurgery again, or you can subsequently receive whole brain radiation therapy, so it doesn't close the door on any other options. The disadvantages, however, are that because we're not treating the whole brain, and so if there are any spots that that are harbored within the brain, then they may subsequently grow, and that's known as distant failure. And so a lot of the literature will talk about a higher rate of distant failure with radiosurgery, and that obviously makes sense. And so because of that, radiosurgery is sometimes difficult to obtain because it remains controversial if you've got more than 4 spots in your head of melanoma. Next slide, please. So what are the machines out there that offer radiosurgery? Well, they basically fall into 3 groups. There's the Gamma Knife, which is the machine that we have at Yale, and we'll talk a little bit more about that in a minute. There's proton beam therapy, and proton beam therapy is, in the radiation oncology world, the best option because it's the cleanest, what they consider the cleanest form of radiation. But unfortunately, the planning required for proton beam therapy takes about 3 to 4 weeks, and so realistically this is not an option at this time for most people. And then the last is Linac-based radiosurgery, and the Linac machine is the machine that's been used by radiation oncologists for the last 50 or 60 years, and those are the machines that have been delivering standard radiation. These machines have been modified so that they can provide now targeted radiation, and so you recognize some of the names there, the CyberKnife, the Synergy, the Novalis TX, and the most recent one is the TrueBeam, which is supposed to be a spectacular machine. And we can talk a little bit about some of the differences in a little bit. Next slide. Sorry, next slide, please. So at Yale, the Gamma Knife procedure, I just wanted to walk you through that. The Gamma Knife treatment is the oldest radiosurgery machine around internationally. It originated in Sweden in the 1950s, actually earlier than that. And remains the gold standard by which all other radiosurgery machines are compared. The Gamma Knife procedure starts at the beginning of the day with the application of the head frame that you see in the top left corner. This is placed with the patient awake. We usually give the patients a little bit of an anxiolytic drug like Versed or Ativan to help them get through the procedure. They get 4 spots of local anesthesia, 2 in the front, 2 in the back, so some Novocaine to make the areas go numb. And then the screws are put in through the frame, through the skin into the skull to secure the 3D frame to the head. I think you can see along the sides that there are measurements, and so what this frame does is it turns every point within the head into an XYZ coordinate. And this really makes radiation planning significantly easier. Next, over in the middle on the top is the patient with the MRI box on, and so based on the frame, the patient then undergoes an MRI scan on the day of their treatment, and so in the upper right-hand corner you can see that every slice on the MRI now has coordinates that allows us to tell where we are in 3D space. Based on that MRI, then a radiation plan is created, and then in the lower left-hand corner you can see that the patient is attached to the treatment table using the 3D frame. This way the computer guiding treatment knows exactly where you are in 3D space, and because you're attached securely to the table, you cannot move at all during treatment. The advantage of the Gamma Knife is that there are 192 cobalt sources that are mounted in a helmet around the brain, and so each radiation beam is just a very small dose, but where 192 beams intersect is where the high dose of radiation is delivered. There are no moving parts within the Gamma Knife machine except to move the patient into treatment position and out again, and because of this, it's actually the easiest system on the market to use. It, however, can only treat the brain, and so obviously is a little bit more expensive to maintain. Next slide, please. So in comparison, Linac-based radiosurgery, Linac-based radiosurgery can be done on a frame-based kind of system, but many of the centers out there obviously advertise frame-free treatment because obviously the thought of having a frame applied is not a pleasant one. What people don't recognize, however, is that you still need to lay still for the delivery of the radiation. And so in the upper left-hand corner, you can see that a mask over the face and shoulders has to be made. And then for the full time of radiation, you actually have to lay pretty much secured to the table in one position with the mask on. And so interestingly enough, there are a fair amount of people who have had both the mask as well as the frame, and many of our patients tell us that the frame is actually easier to tolerate. Linac-based radiosurgery in the majority of centers is not delivered in one day. So with the immobilization mask on, the patient undergoes a CT scan, which is in the right upper corner picture. It's the left-hand picture. And then you have to have an MRI also with the mask on. These two images then need to be merged in the planning computer, and planning itself can then take a significant amount of time. The treatment itself is always based on the CT, not the MRI. And so it's our feeling that if you can turn this over in 24 hours, that's great. But if there's any significant delay, and that delay is usually about 1 to 2 weeks in most centers, then you're not really getting up-to-date information on the MRI at that time. Based on the merge of the two images, however, then you create a treatment plan, and then as you can see in the lower bottom corner, instead of no moving parts, you now have a moving arm that delivers a beam of radiation at a time. And because of the moving part, it actually requires a fair amount of physics checking to make sure that the radiation doses that are being delivered are exactly what have been planned. Again, making the Linac-based radiosurgery a little bit more difficult overall. Next slide, please. Okay, so at our center, what do we tell people are the outcomes following radiosurgery? So what we went actually back over all the patients that we treated over a 3-year period a couple of years ago. And we looked at 500 metastases, and about 70% of those spots actually shrank to about half their original size by their 6-week or 3-month MRI. What we're able to show, however, is that in almost all of the lesions do not disappear. So whatever shrinkage you get by about 3 months is where they stay, and they will just sit there. And so we talk about an 85 to 90% control rate at a year. In other words, that they don't grow again within that 1-year period in 85 to 90% of lesions. What we were able to show was that most of our patients who were managed with radiosurgery actually had good control of their central nervous system disease, and it wasn't progression of brain metastases that caused their death, but rather progression of their systemic disease. What we did, however, also show was that if you had good control of your systemic disease, that on average most melanoma patients needed at least 2 sessions of radiosurgery because of that distant failure phenomenon that we had talked about before. Next slide, please. Okay, so what are the complications of radiosurgery? So we break down complications into those that are acute, in other words, within the first couple of days after treatment, subacute within the weeks to months after treatment, and then chronically, so beyond 6 months or so. And so in the few days around radiosurgery, obviously the headache from having the frame screwed on your head is can bother some people. The local anesthetic and having the frame put on can also cause some facial swelling, particularly around the eyes and things like that, but that usually settles in a day or two. Just as the brain metastases themselves can cause seizures, radiosurgery as an insult to the brain surrounding the lesions can cause seizures also. Similarly, it can also cause swelling. So just as any injury can cause swelling to the brain, high-dose radiation can be considered injury, and that can cause swelling also. Now these are obviously they're low risks, but because we don't want this to happen to our patients, we go ahead, or our practice has been to go ahead and give most patients a prophylactic dose of anti-seizure medicine right before treatment, as well as a prophylactic single dose of steroids. And so I know that most melanoma oncologists don't like the use of steroids, but the single dose doesn't seem to really impact people significantly. In the weeks after radiosurgery, we can see a transient size increase in the lesions themselves. So if we image people before the 6-week time period, sometimes we can see that these lesions increase in size, and we think that that's just a response to the radiation. And so because of that, we don't image people earlier than the 6-week time period. In addition to that, there is still the risk of bleeding from the melanoma metastasis. What we did do is go back and look and see if we thought radiosurgery was causing the hemorrhage, and the rate of hemorrhage after radiosurgery in the first 6 weeks is pretty much the same as it was before treatment. And so we think that what's going on is that the radiosurgery does not fully protect you against the risk of bleeding until it's fully taken care of the spot at around 6 weeks or so. In the long term, people fall into 2 categories. The majority of people will not really have trouble from their metastases again, but there's a small group of people who living longer than 9 to 12 months in whom we start to see these spots start to regrow. And this occurs, we think, in the order of about 5% at this time. And what we've been starting to learn is that not all of this, what looks like regrowth on MRI, is tumor regrowing, and some of it is an adverse reaction to the radiation itself. And so we know that even with whole brain radiation therapy, that there can be adverse radiation effects beyond a year or 2, and so we're probably seeing the same thing with the radiosurgery. Next slide, please. Okay, and so it's been, we've obviously with the new targeted agents that are coming out that are immune-based, we have talked a fair amount at our own center about the interactions between gamma knife and systemic therapy. And so the bottom line, unfortunately, is that there's very little known about the effect of systemic therapy in the brain. If we look at all the clinical trials that are out there looking at the benefit of agents like ipilimumab and vemurafenib on brain metastases, there are isolated case reports, but in all honesty, for all the trials that have been out there, if your central nervous system lesions have not been definitively treated, then you're excluded from clinical trial. The other problem with the data is that we have no idea if the systemic agents even penetrate the brain. It's obviously difficult to biopsy the brain to get drug levels. We have no idea what concentration, if they do get into the brain, at what concentration they get in there. And lastly, we have no understanding of the mechanism of action. You know, and a good example of this is ipilimumab. We believe that ipilimumab probably doesn't even get into the brain, but it may sensitize the T cells to tumor surface markers, and it may in fact be the T cells that are getting into the central nervous system. So it's just, there's so much that's unknown about that. Next slide, please. So regardless of this, though, what we wanted to do, we did collect a bunch of patients in whom the melanoma oncologists had been able to give ipilimumab, who had also had gamma knife radiosurgery, and so we wanted to go back and have a look and see how these patients did. And so as many of you know, in the New England Journal of Medicine in 2011, they showed that even in patients with stage 3 and 4 melanoma, that there was a survival benefit with ipilimumab. And so Here at Yale, we looked at the 77 patients who in the prior 8 years had been able to get ipilimumab, and you'll all remember that during this time ipilimumab was only available on clinical trial. Next slide, please. And what we were able to show was, in fact, the same overall survival, even in patients with brain metastases. And so the solid line at the top is those patients treated with ipilimumab, and the one at the bottom, the broken line, is those who did not receive ipilimumab. And so if you look at our overall cohort, the numbers on the bottom of the graph, our overall median survival was 8.8 months for the whole group. For those who received ipilimumab, though, median survival was 21 months compared to those who did not receive ipilimumab, only 5 months. And so, you know, what we again, what I think what this emphasizes is that it's not so much you know, that having brain metastases alters ultimately your survival, but that if you're able to control the brain metastases, that ipilimumab then has the opportunity to improve survival for the patient. All right, next slide, please. What we also did was then go back and look at our radiation experience in those patients who were who got ipilimumab. And so what we found was that the median number of metastases that was treated at the initial radiosurgery or gamma knife session was 2, ranging from 1 to 16. So we're obviously a rather aggressive melanoma gamma knife site. The median interval between radiosurgery treatments, and as we had talked about, often melanoma patients will have to come back for more than 1 radiosurgery treatment. The median time between the first and second treatments was 6 months. When we had to treat a second time with radiosurgery, the median total number of metastases was 8 at the time, and you can see that we treated up to 52 for somebody. And the overall median number of times that we had to repeat radiosurgery was 2. So in other words, the median overall number of times that people had to be treated was 3 times the original time and 2 salvage sessions. Well, on the flip side, though, what we were able to show was that about 1/3 of our patients only got treated with radiosurgery 1 time, so they never needed salvage radiosurgery. And with our aggressive radiosurgical philosophy, we were 2/3 of patients actually never needed ultimate whole brain radiation therapy. So we were able to provide good central nervous system control of brain metastases in a good percentage of our patients. Next slide, please. The last thing I wanted to talk about was something that our melanoma oncologists have brought up. So as we had talked about before, if you live long enough following your radiation, you may start to develop adverse effects from the radiation itself. We believe that some of these adverse radiation effects may be immune-mediated, and so the question has been raised as to whether or not the immunotherapies that people are getting systemically may be making the adverse radiation effects worse. And so what I wanted to show you, and this is just all the way to the left, the picture is that of the arrow moved, I'm sorry, but the treatment spot itself that was treated 3 months later, you can see that the spot is stable with very little reaction in the surrounding brain. But then at 13.5 months, so all the way to the right now, the picture on the top shows that the spot looks like it's starting to grow, and the picture on the bottom now shows that the brain is actually reacting, and all that white stuff in the brain is water or edema. And this is and so we ended up biopsying this lesion, so taking a small portion of it surgically, and there was no tumor within there, but just a reaction, an inflammatory reaction. And so we're in the process right now of trying to look to see if we think that agents like ipilimumab or vemurafenib may in fact make the adverse effects of radiation worse than in other tumor types, and the data is not in on that yet. Next slide. And so I think that just to sum up, here at Yale we have moved from a whole brain radiation therapy based treatment for melanoma to something that's essentially almost all radiosurgery, with whole brain radiation therapy being used as a last resort palliative treatment. With this, we have been able to offer good control of brain metastases for the majority of our patients, and obviously our patients are living long enough now that we're having to deal with some of the side effects, and so there's a lot more to be done and questions to be asked about the interaction of targeted therapy with radiation management of brain metastases. And that's it. Thanks.
Okay, am I here?
Yep.
All right. This is Catherine Poole, and I have questions now to ask from our constituency that have been sent to us over the past weeks. That was a wonderful presentation. I really, really enjoyed it and learned a lot. I think when I first started in this field 20 years ago, if you had a brain met, it was, very, very sad for people. And now it's just not a huge deal.
Right.
And that's the good news. So our first question is, what are the upper limitations for Gamma knife, like lesion size and number of lesions? Like what is the limit?
Let's start with size, because that's the easier question to answer. What we know about the side effects of single fraction radiosurgery is that the larger the size, the more normal brain surrounding this area is receiving radiation. And so what limits the ability to give single fraction radiosurgery is the amount of surrounding normal brain. So actually what we talk about is not so much a single dimension, but volume of lesion. And so this is obviously difficult to get off a radiology report, but typically what we tell people is that if it's a round lesion that's about 2.5 to 3 centimeters in every dimension, then that's probably too large to treat with radiosurgery. What happens, though, is that sometimes people can have sausage-shaped lesions that are 3 centimeters in one dimension and not the same across, so only a centimeter or so across, and that does not necessarily preclude you from radiosurgery. As far as number, this is very controversial. What the literature basically says is that if you have 1 to 4 metastases, that there is probably a survival and functional benefit to radiosurgery versus whole brain radiation therapy. Beyond, so 5 and beyond, however, is something that's very center dependent. And also very insurance dependent. So the insurance companies have the literature that says that 1 to 4 is fine, and 5 and beyond is not. And so a lot of it depends on the amount of work that your center has done to work with the insurance companies to kind of get an understanding of what's acceptable and what's not. And within the Gamma knife community, we're still having that issue. From a practical standpoint, so if you are at a place where it doesn't matter how many you have, the issue is that each lesion itself takes probably a minimum of 10 or 15 minutes to treat, and each lesion is treated independently, and so physically it would require, once you get beyond 20 or so lesions, it becomes many hours of treatment all at the one time.
But wouldn't that be worth it to avoid the whole brain? To be worth that?
Yes. So that's we think so, but not everybody agrees with us. I can't tell you that the treatment couch is the most comfortable thing to lay on. Most people will tell you that after a while that like their neck and back and things like that become very sore, and you can take breaks in between, but it really does become a very, very long day. So the whole process, it takes a minimum of 3 or 4 hours just to treat one lesion, because you've got to have the head frame put on, go up to MR, come back and get the planning, and the planning itself also takes incrementally longer the more lesions you have. So, obviously the more lesions you have, the longer each part of it takes, and it really does. I think that, we have the Gamma Knife Perfection here at Yale, which is the machine that was specifically designed for multiple metastases treatment. And even with that, once we get beyond 20 lesions, it really becomes a very long day for everybody.
Well, I find that our patients never complain about this. So honestly,
you've got some very stoic patients. I unfortunately don't benefit from the same population.
Well, at least they report on our forum, oh, it was nothing, it's not a big deal.
Well, so, melanoma patients are very stoic in general, but,
they're the best.
Yeah.
They're the best. We put up with a lot because, where we've been.
Right. Absolutely.
Some of these questions you've kind of been over before, but I'm going to ask anyway. You talked a lot more about IFI and Yervoy and brain mets, but I believe GlaxoSmithKline had some trials they included brain mets in some of their BRAF and trials, and I wondered if you had reviewed any of that or had any opinion about their BRAF-MEK combo or BRAF alone. And
Right. So I think that I think that basically what was published in the New England Journal of Medicine for vemurafenib, is basically along the same lines as the ipilimumab. That the patients with brain metastases were again excluded unless they were definitively treated either with whole brain radiation therapy or radiosurgery. I think that there's probably even less literature, out there with the BRAF inhibitor agents. I know that our own melanoma oncologists initially believed that that the BRAF inhibitors cross the blood-brain barrier. I think, though, that that experience has demonstrated that while there may be some patients who do benefit from that, there are a significant number who also develop brain metastases despite it. So even with excellent systemic control, we can still see recurrence of brain metastases on this agent.
Okay. I think there was a specific trial, but it was a small number with the GSK BRAF that did show some promise. So.
Right, and so I think that, as with all agents, there's probably a group of people that may benefit, but, unfortunately the rest of us also have a handful of people who we can show have progressed in their central nervous system despite good systemic control on these agents. So it doesn't work for everybody.
But the beauty with all of these so far with our patients is they're able to, either go off of the agent they're on, have the gamma knife, and then go back on.
Right, and so we don't actually ever stop the agent.
Oh, you don't stop? Okay.
No, we actually just treat right on the agent. So.
Yeah, I kind of wondered why they would do that, but I think some were doing it. Maybe it was because of the trial requirements they were doing that.
It's possible. Yeah,
yeah.
I think that, it's probably, some of it's also a bit left over from the original whole brain radiation data where, systemic therapy had to be stopped during the delivery of radiation because it just was not known if the agent was a radiosensitizer.
Okay.
And so by the same token, we try not to give the agent the day that we're doing the radiosurgery. Not that anybody can make it there anyway.
Right.
But what we've not actually specifically said you need to stop or whatever. I think that our oncologists are very good about just coordinating with us.
Mm-hmm. Okay. The next question, you answered pretty well about the pros and cons of wide brain radiation versus the gamma knife.
Mm-hmm.
Has the wide brain radiation, though, changed a little bit? Because I have had patients go through it and not seem to be very debilitated and go on to improve. So has that changed in any way, or is it still same old?
I don't think that it's changed considerably. I think that in people who have good cognitive function, there has been a tendency to lengthen the duration of the treatment from 2 weeks to 3 weeks. And what that allows you to do is that it allows you to give a smaller dose each day.
Mm-hmm.
And there's some belief that by doing that may ultimately result in cognitive preservation. I think, though, that all the studies that have been done have not actually demonstrated any benefit overall. I think that the bottom line is that many people can go through whole brain radiation therapy without cognitive deficit. It's just that, and so it's the same with all risks. We can quote a percentage risk, but the bottom line is, we have no way of predicting whether you fall into the good percentage or the bad percentage.
Mm-hmm.
And without the ability to predict who's going to develop neurocognitive problems, I can't tell you if you will or won't if you were to get whole brain radiation therapy.
Okay. So is there a different machine they use for the wide brain radiation? That are there newer, different ones, or is it pretty much?
No, whole brain radiation therapy. The machinery for that is pretty standardized.
I'm at fault.
And that is that Linac-based machine that
Okay.
that you saw. Yeah.
Okay. So what's the best sequence of gamma knife and the new therapies for melanoma? We just said that you could continue being on the therapy and having it. I mean,
right.
So is there a sequence to that at all, or?
I don't know that we know that there's a sequence. I think that in all honesty, our medical oncologists just start it whenever they can get it, and we get people in for radiosurgery as soon as we can. So we don't necessarily wait for each other. We kind of do them concurrently.
So are all of your patients, I'm kind of skipping down to the last question, but I wanted to ask this one first.
Okay.
Are you moving up the time for brain scanning, the MRI with contrast? Is that done more readily and early in a melanoma diagnosis, instead of waiting? Since
right.
If you find the Mets early on, you have a better prognosis?
Right. And so basically our melanoma oncologists, just the minute somebody presents back with metastatic melanoma, they start on an every 6-week to 3-month screening schedule.
Wow.
Yep, and they just and so they can go for a while, obviously, without any brain metastases. But I can pretty much guarantee that if they see our medical oncologist, that when they present to us, they're usually only a couple millimeters in size,
Mm-hmm.
which is great. Those are the lesions that respond the best to treatment.
So you would encourage somebody who's newly diagnosed stage 4 to get a baseline?
Absolutely. I think, though, that it's, it all comes down to a matter of what your insurance company will allow and things like that. The advantage of having worked in a group here is that is that, our philosophies have all gelled together, and so when the insurance company balks at the fact that we're rescanning these people with no symptoms and and no other indication for scan, that that we can pull our data up and say, yeah, but here's how often it actually happens. So yes, I think that certainly when metastatic melanoma is diagnosed, that there should at least be one screening MR of the brain. I think, though, that even without symptomatology, that if it can be organized, that you can get regular screening, that's probably the best way to look for them.
Good. I'm glad you're helping the patients with the insurance, because that's the last thing they need to have to deal with.
Right. No,
to fight with the insurance.
Yeah.
I had a question from the UK. Apparently, their system there is that they have to have a biopsy in order to qualify for the gamma knife. And so the person wondered if the MRI might negate the need for the biopsy.
So probably not. When we counsel our patients about gamma knife, we tell them that we're providing their treatment based on the presumption that this is melanoma metastasis. When you have just one metastasis, then there's always the possibility, especially if you've not had any prior screening MRs, then it's always possible that we could be wrong about your diagnosis. And so we do counsel patients that, the option is that we could prove it to you by biopsying it, or we could just treat it presumptively. If you have more than one lesion, then in general it's less likely that the diagnosis is incorrect. But, that just may be the way they've set it up over there, and it may just be that, that they've run into trouble in the past with making incorrect diagnoses. The MR is not, there is no way on the MR to make a definitive diagnosis of melanoma metastasis.
Well, how would you do a biopsy? I mean, would that be like a needle biopsy?
Yes, absolutely. Yeah, it would just be, there's the standard intraoperative way of doing that. But yes, with a needle.
I would think, with thinking of the skull and so on, that might be difficult.
Yeah, it's actually, obviously, it's compared to other neurosurgery, it's relatively low risk. It's considered a small neurosurgical procedure, but it does require, anesthesia and all that kind of stuff. So, I think that at our center we've decided it's okay not to biopsy everybody, but I wouldn't necessarily fault them if they've had trouble with diagnoses in the past.
Okay. And then I had an individual sort of question, and you referred a little bit to the edema that sets up from a brain met, and she wanted to know, and actually her appointment's tomorrow.
Okay.
Just to weigh in a little bit, and I'm not sure, I had to develop the question from her paragraph, but hopefully I'm right. Okay. What should she do when the tumor has shrunk, but the edema keeps growing, and every time they put her on steroids and then they take her off the steroids, the edema comes back? And so they seem to be having issues, and now she's having some issues of double vision. So.
Okay. So I'm sorry, let me just clarify. So she's had treatment for her brain metastasis already, and the lesion shrank, but the edema is growing. Is that correct? Okay. She doesn't say how long ago she had the treatment.
Let's see, she's been on steroids for 3 months.
Okay.
First, the tumor was bleeding and also was showing symptoms. Within 2 weeks, it was stable. It started to wean her from the steroids, and the edema began causing issues.
Okay. So, so edema is usually caused by one of two things. It's it could be caused by the fact that the melanoma itself has not been completely controlled. And so even though it may have decreased in size and stabilized for a while, it may not have been completely treated, and so it can still be causing edema. Or it could be from the radiation. So unfortunately, without the details about the radiation treatment itself, it's a little bit hard to know which one of those it is. Unfortunately, the only treatment for edema at this time is steroids. And so I think that if she's unable over the next couple of months to wean off the steroids, then they're going to need to choose an alternative form of treatment for the area. And probably what she'll need is a biopsy to try and work out whether or not the lesion is controlled. And then based on the results of that, then treatment can be delivered.
She said there was 20% shrinkage and that they couldn't do a craniectomy because it's deep in her speech area.
Okay. They could still biopsy it, though.
Okay.
You know, so I think if there's any question of what's going on, then that's probably what they'll offer her next.
Okay. Great. Well, that's all of our questions for tonight, and I can't tell you how much we appreciate your time and energy that you've put into this. It's a wonderful educational opportunity for everybody here. So thank you very much.
Absolutely.
And,
thank you, Catherine. It was great being here.
We'll have to have you back again soon in the future when things get even better for us.
Okay. All right. Have a great night.
You too.
Okay.
Bye-bye.
Okay. Bye-bye.